Hello, everyone, and welcome to the seminar. I am Jamie Marbo, and tonight's topic for our webinar is the 4 pillars of patient acceptance, how to effectively allow your patients to own their own disease and improve treatment acceptance. So I want you all, since we're not sitting in the same room, and this is a webinar, I want you all to imagine that if you could wave a magic wand to create your ideal day, your perfect day, what would that look like? So for doctors in the listening, think about what your chair would look like, the flow of your patients, the type of patients you have in there, treatment, option, outcomes. Maybe think about what would that hygiene exam look like. Hygienists that are listening, what would your perfect day look like? How would your patients respond to when you recommend periotherapy to them? And if you're anything like me as a practicing hygienist, of course this magic wand doesn't exist, and some days we have better outcomes than others. But across from that list, if you wrote them down, I want you now to write down a list of the obstacles that you may encounter or the roadblocks that happen when you are creating or trying to get through your perfect day. Are the patients sometimes late? Do they sometimes they're not listening to the options and the choices that you've given them? So when you think about that list of the many things that could become an obstacle to not give you that perfect and ideal day, typically, no matter what part of the world or country that we're in, as a national coach and hygienist myself, there's many roadblocks, but a lot of us have the exact same roadblocks. We deal with the same things, some of the things that I've mentioned. So hopefully at the conclusion of our webinar, we might be able to, I hope that I will be able to provide some solutions for some of these barriers that we have identified. So save your list so that you can follow up on the barriers that we may have solutions for and the remaining items on your list. This will be an excellent springboard for topics of discussion at your next team meeting or at the morning huddle. Because there's a lot of common obstacles, I'm going to narrow this down to a select few. They are typically patient acceptance and getting the patients to own their own condition, and also how technology can sometimes create some reasonings of us not using it. Maybe it's the lack of technology in our operatories. Maybe it's that new technology isn't something that we were raised with, and that when we first started hygiene or practicing dentistry, technology wasn't around. And so it may be that we aren't using the technology. Finding a strong why for its use and not knowing how to use technology as a driver for case acceptance and how to use it to actually build value. For those of us that are seeking to overcome the barriers that we've listed, we're going to focus first on the patient acceptance. So getting the patients to own their own disease. The 4 pillars of patient acceptance are consistent data collection every time, informing the patient as to what their disease is, engaging the patient. This is where technology is one of our biggest aids in helping patients understand the why to increase their acceptance. And then using consistent messaging. Let's go one by one. So consistent data collection. The best way to ensure adherence to consistent data collection is to develop a practice standard of care document. At Inspired Hygiene, where I am a national consultant at, Inspired Hygiene provides our private coaching clients this step-by-step standard of care document, So when we do our in-office coaching, hands down, this is one of the most impactful exercises that our offices do together. So how many times have we all experienced the frustration of opening up the patient chart only to discover that the other hygienists haven't been doing full perio chartings on recare patients once a year, like we had discussed in our last staff meeting? Or how many times have you seen a patient with outdated films, even though the doctor has asked for vertical bite wings annually? And doctors, how many times have you gone in for a hygiene exam and you've asked the hygienist to have an intraoral image or two, or several of them, waiting for you so that you can show the patient when you're doing their restorative exam? Often offices talk a big talk about implementing this or that, but at the end of the day, there's no mechanism of accountability. Creating a written document or standard of care will help ensure that the practice has the solution, that everybody has the same document, is speaking the same language and providing the same exact services that we agreed to. So if you would like to have a standard of care document, you can go to inspiredhygiene.com/standard of care. And this is a Word document. You can download it, and then you can add things, take away things, whatever you want to do. You can get this customized to fit the needs of your practice. So getting the standard of care document is a very important outcome for helping keep the consistent message. One second, I lost my notes here. Okay, so after the standard of care document, where you've all sat down and you have every team member, everyone from the admin to the dental assistants to the hygienist and doctor, if all parties in the office participate in creating the practice standards, this is an effective way for everyone to feel like they've got skin in the game. They can all feel like they've had input instead of the doctor coming in and stating, thou shalt from this day forward start implementing this and that. So getting everybody to feel that they're a part of this standard of care is one of the best ways to find compliance with the whole team. And then also have everybody sign it and date it. The standard of care, once it's created, needs to be given and gone over with new employees so that they understand what the standard of cares and philosophies are of the team. And you can ask he or she, the new employee, if they have any input. Maybe there's things that they did in their previous office that they found effective and that worked. And you can add them to this document, go over them with the rest of the team, and have everybody sign the document. Putting this into motion isn't as hard as you think. It's just taking the time and making sure that you implement it. What other benefits do you think you can think of for developing, writing, and sticking to a standard of care? When it comes to consistency within the hygiene appointment, we break this down into a 20-20-20 rule so that you can hopefully stay on time. Now, in my webinar that I'm doing tomorrow night, we're going to be going over the 60-minute countdown, how to stay on time so that you don't have the 60-minute blow up. So the ultimate hygiene exam, what this is in the first 20 minutes, you will be gathering all of the data that is necessary before you ever pick up a scaler. So that would include health history documentation, blood pressure screening, the radiographs, intraoral images maybe, the full mouth probe, and anything else that you need to know in order to move forward with your treatment recommendations. Also, having all of this before you pick up a scaler and knowing exactly what disease level the patient is at will help you when the doctor comes in to do the exam. So when she comes over, you can have a very good handoff with your doctor as to the disease level that the patient is currently exhibiting and or any perio recommendations that you might have, so that you can help co-diagnose with the patient and with the doctor, so that when the doctor is looking in the patient's mouth, he or she can back you up. So making sure that you know exactly what the disease level is helps get rid of that pit in the stomach if you get started without knowing all of this information and you wish you could backpedal out of that hygiene appointment and do something different because they're possessing more disease or more bleeding or more buildup than what you had originally recommended. We'll go more into the 20/20/20 in tomorrow night's webinar. So the second and third pillar of patient acceptance kind of go hand in hand. So informing the patient and engaging the patient in their co-diagnosis. So what this does is this helps the patient understand exactly what you're doing as you're doing it. This builds value for all of the services that you're providing. So an example that I want to give you is this. So you take your very expensive classic car, your baby, into the dealership for its routine service. You sit comfortably in the customer waiting area and you're waiting for your car to finish getting its checkup. After an hour or so goes by, the receptionist informs you that your car is done and that the mechanic has recommended some added things that need to be taken care of. For instance, the front rotors and the brake pads need to be replaced. The car is out of alignment and the arm bushings need to be replaced. And you have an oil pan gasket leak. And the fee for all of that will be about $2,900. You're totally confused and shocked because you know that you're actually a little mad because you're just coming in for your routine checkup and your car has been running perfect according to when you're driving it. So you feel a little blindsided because you're not a part of the car's inspection process. You weren't walked through the inspection as they were doing it. And in this case, they just spring it on you, and you're in for almost $3,000 without you even knowing anything was wrong. The same thing can be true when it comes to our routine service patients, our 6-month ReCare patients. They come in to see us, and they think that they're just getting a routine checkup, and lo and behold, when you spring the news of disease on them and that the treatment needs to be different, they are shocked and they're even a little mad because they haven't heard you talk this way before, or maybe you didn't bring them along in the gathering of the data, and all of a sudden you're telling them that they need something different. And this is what we refer to as the kaboom effect. Kaboom, Mrs. Jones, you have a disease that we need to treat differently than what we've been doing. And kaboom, you now need a crown and build-up to help repair this tooth that's going to cost you $3,000. And Mrs. Jones is upset because she just came in for her routine checkup and nothing hurts in her mouth. Nothing yet. We all know that, but when we gather the data in silence, and many of us have done this, I know that for many years, early on in my career, I would chit-chat with my patient, and I would not bring them and involve them in the conversation of the gathering of the data. And I would wait until it was uncomfortable, and all of a sudden I had to spring the bad news onto them. So one of the ways to keep the patient engaged during the appointment is to do what we call the 3 Ps. So when you're doing, for instance, a head and neck cancer exam, you need to verbalize to them that that's what you're doing. If you don't tell them it's a head and neck cancer exam, they might just assume that it's a complimentary chair massage. So a key to verbal skills that all of us can easily implement tomorrow is what we call the 3 Ps. When we go in and do our private coaching, our client after client tell us that this technique is by far one of the best tools for the patient engagement. There is a system of how to use the 3 Ps for the perio treatment and also restorative planning. But right now we're going to go over just the 3 Ps for the perio piece. And you can implement this. You'll be able to figure this out, how to implement it with the restorative piece. So step one is what we call preparing the patient. I'm going to call the patient for action. So I'm preparing the patient for what she's going to be listening to. So Mrs. Jones, included in your visit today is your periodontal evaluation. This is a screening for your gum disease, and I'm checking your bone level. I will walk around this little instrument that looks like a ruler, and I'm going to be calling out some numbers. I want you, Mrs. Jones, to pay attention to the numbers I'm calling out. The numbers between 1 and 3 are considered normal. Anything above that we'll be concerned with, and we'll discuss that when we're done. I also want you to know that healthy gums don't bleed. So basically what I'm doing is I'm informing her very simply that 1 to 3 is considered normal. I don't say healthy because we can have unhealthy bleeding 1 to 3 millimeter pockets. So we just say that they're 1 to 3 is normal. Anything above that will be possibly be concerned with, and we'll discuss it. And healthy gums don't bleed because we all know that they think that their gums have always bled and that's just normal for them. Well, it may be normal for them, but it's not healthy. So then I go along and I am doing the probing, and I'm calling out the numbers. If I'm lucky enough to have a headset or VoiceWorks through Florida Probe where I'm calling out the numbers into a microphone and the numbers are being repeated out loud, or if I happen to be lucky to have an assistant that's helping me gather the data, that's pretty easy to be calling those numbers out loud. But when you're doing it on your own, what I do when that has to happen, when I can't have help, which is very necessary in order to be accurate and to have the time-saving part of our 60 minutes go well. If I have to do it by myself and putting it into my software, I usually will probe around 2 teeth and I'll have 6 numbers. And as I'm putting that into my software, I'm calling that out. So I'm saying 324, 425. So Mrs. Jones is hearing that. When I'm done with my probing and recording my recession so I can have my CAL, my clinical attachment loss, I then hand the patient a patient mirror, and I do what's called the tissue sweep really quick. I don't rely on my bleeding with bleeding on probing only because I'm only going in and touching the attachment, and the infection is more prevalent on the whole epithelium lining or the wall of the epithelium. So I take my probe just barely off the attachment, lift it up, and I take it away from the tooth, and I'm almost on the inside of the pocket blanching the tissues, and I'm just doing a tissue sweep around those areas that maybe didn't bleed when I was doing the probing. And I am now, the patient is watching me, and I'm calling out the bleeding sites as well. So the distal of 2, buccal of 3, mesial of 3, calling that out, and the patient is seeing the bleeding for herself. I then sit the patient up and I start to talk to her, before I sit the patient up, and I'm going to go over this in a minute, but when I sit the patient up before that, I will actually take an intraoral camera and take some images, and I'll discuss this intraoral camera that I think is a game changer in just a minute. But the third P after the probing or the perio-charting is the presenting. You're presenting the treatment options and or you're presenting the findings of the disease to the patient. So I sit Mary up or Mrs. Jones up, and I say, Mrs. Jones, you heard me call out the numbers. What was the highest number you heard? And she'll answer. And what was the lowest number? She'll answer. And I'll say, and do you remember what we talked about, what was considered normal numbers? And so I start the discussion in that direction because she's already paying attention and she's already forming an opinion in her mind that something's different because I've given her a baseline to listen to for those numbers. I also say, you saw me doing the tissue sweep and you saw some bleeding in there. Would you say that you have light bleeding, moderate bleeding, or heavy bleeding? And I let her rate herself because what happens is that we see bleeding all day long, right? And so we aren't the best, we can't identify bleeding as well as they can because for us, we may have just saw, Mr. Johnson in the chair and he was bleeding like a stuffed pig, and because Mrs. Jones isn't bleeding as much, we kind of minimize her active disease level. So it's best for her to say it, and I always agree with the patient. And I say, you're right. And I'll say, what did we tell you? What did we talk about bleeding? And she'll say that it's not healthy. So that's how I get the patient informed and engaged in the disease process and the gathering of the data. I do the same thing with the images I'm taking and with the radiographs. If I see something on there, I just start talking about it right away. I start questioning her. If on the health history they've circled certain things that we know as a two-way street with periodontal disease, I start discussing that lightly and briefly. And then I come full circle after I've got this last bit of information, which is what I consider a game changer in intraoral cameras. This is called the SoPro Care camera. The SoPro Care camera is a game changer because it has some modes on it in its uses that is different. It helps the patient see their disease in a different manner. It uses fluorescence and chromatic amplification, something that the medical industry has been using for years. And now finally it's in dentistry. And Acteon North America has totally coined this, and they have knocked it out of the ballpark, to be honest, with this camera. So let's go into the camera. So after I have done the full mouth perio charting and I've done the tissue response, I then know that I'm going to be recommending perio treatment. So I get out my SoPro Care camera and I start taking some images. Now the SoPro Care camera has 3 different modes. The 3 different modes are the daylight mode, which is what you see on the left-hand side here, and that's what most cameras show. It does magnify, but it is just a daylight mode. The second mode is the perio mode, and I'm going to explain how this happens in just a second. And not pictured, that I'm going to show you in a minute, is the cario mode. So we have the daylight mode, we have the perio mode, and we have the cario mode. The perio mode, what it does is it highlights the dental plaque and the gingival inflammation. So what you see on the right. This mode uses fluorescence and selective chromatic amplification to evaluate the patient's dental hygiene. It highlights the dental plaque and displays gingival inflammation without having to use disclosing solution. And finally, and the thing that helps the patient own their own disease is that when we're looking with most cameras at their tissues, yes, it is magnified, but the tissues still look fairly close to what they see in the mirror every day. We can scrape off plaque and we can show that to them, but when you're using this fluorescence, it really changes how that looks to the patient. So the white light goes in, and it goes into, the blue light from the camera goes into the bloodstream, and then the white light, it fluorescence inflammation, and it creates this magenta color that you can see here. So this inflammation, this magenta color, would not be there if there was not indeed inflammation in the bloodstream. So let's just look at a couple more pictures here. Don't you think that your patients can see a difference with the way this camera can show them? I think this has totally helped. Well, I know that this has totally helped my treatment success outcomes. So what happens is the light goes in, and the light actually looks for a change in the inflammation and shows that. In the cario mode that you see on this slide, the cario mode is what the light will go in, and if it's gray, it's healthy. But if it seems black or suspicious caries, you get this black or red coloring, and this is a sign of possible incipient caries or suspicious caries that need to be treated. And so when on the cario mode, the wavelength is 450 nanometers, and what it does is it detects structural changes in the dentinal tubules. So here you can see between the daylight mode on top that there's obviously some slight staining in the pits and fissures, but when you switch it to the Cario mode, the evidence becomes clear, and the red indicates that there's a suspicious area or a cavity. If you're concerned, you can then do whether this is a false positive, you just have to go in and do a professional cleaning, and if it still shows up, you know that it is definitely needing to be treated. So don't you agree that this technology, along with our the way that we typically have collected data, could be the difference between the patient really being able to identify their disease level and own it? So just to recap on the 3 Ps, we are preparing the patient for what we're doing. Mrs. Jones, pay attention to the numbers I'm calling out. Then the second P is the probing or the perio charting. And then the third P is the presentation of the treatment plan and the disease level that they have. I then take the intraoral camera, the SoPro Care, and I am taking some images of the inflammation and possibly any suspicious lesions that I may see so that the doctor can have these during their exam. Now, the other great thing about this camera is that there's no buttons to switch and push and to fumble with. There is a toggle. It's just a simple toggle that switches between this. The other thing about this camera that I love is that you can do a full face view, so no more external cameras with all of the lenses and all the cheek, you still use the cheek retractors and things, but you don't have this big camera with all these settings on it. You take this camera at at one level and take a full face. You can take a half arch at a time, full mouth bites, and then you can switch it to this close-up view. It has a little guide that goes with it so that you have a steady hand and you can just slide it, rest it on the teeth. It's autoclavable, and that little sleeve fits over the end of the camera, and you just rest it on the tooth and you slide it as you're taking the images. There's also a foot pedal that you can push if you want, or there's a little hand control if you have an assistant that can help you with that. So moving on to the last of our 4 pillars. This is the consistent messaging. Now, the consistent messaging is so important. Consistency is the difference between the patient being confused or not confused. This is also the piece of the bad cop and good cop mentality that often offices, when I go in and train, I will see. We'll have one hygienist who is recommending perio and being proactive with her recommendations, and then I'll have another hygienist who is a Weight Watcher, and he or she is just sitting there until the disease is at a level that is unmanageable, but it's a slam dunk to recommend it because of the radiographic evidence, or now there's a 6mm pocket so it's easier. When in actuality, the best time to help our patients own their disease and control their disease is at the reversible stages of gingivitis. Gingivitis, if you remember, is the gatekeeper to periodontitis. You don't ever see anybody having periodontitis without gingivitis, but you will have people with gingivitis that don't have periodontitis. So we need to get it at its reversible stages. So the consistency in the messaging is everything from how everybody probes, what it is that you're charting. Is everybody charting bleeding on the probe sheet? Is everybody recording the recession, mobility, furcation? And what is it that we are calling disease? At what level will we recommend something different? What will our treatment options be that are different? We have to make sure that everybody is speaking the same language so that the patient is never confused. Because whenever the patient is confused about their treatment options, that creates bad outcomes for everybody, the office and the patient more importantly. So Getting the perio classifications down is key. Now remember, we're not talking about just a little bit of pinpoint of bleeding. We need to talk, we're talking about bleeding that is 15 or more sites, and it is falling into that triangular part between the two teeth, and we are charting the bleeding. Gingivitis has no bone loss, and it is pseudopockets with no radiographic bone loss and or 3 millimeters or less. Early is bleeding with slight bone loss, 4 millimeters, and this is all from the ADA and the AAP. And also there is no furcation involved in early periodontitis. If you have furcation, they are moderate to advanced. And then moderate has bleeding with slight to moderate bone loss, 5 millimeters or less. Advanced is bleeding with moderate to severe bone loss, and it's 6 millimeters or greater. You need to take into consideration the CAL because the clinical attachment loss or level is a great indicator, along with bleeding, that there is continued loss of attachment. So you may have a 3 millimeter pocket, but you have 2 millimeters of recession, and if that starts to bleed, you've got active infection, and that is a 5 millimeter attachment loss. So recording all of these and deciding at what level do we involve a different type of treatment for our patient or recommend a different treatment for our patients is imperative. So getting everybody on the same page and agreeing to what is disease and what's not. And it's as simple as that. I ask myself on every patient, does my patient show disease, exhibit disease? And I always assume disease and let them prove health. But does my patient exhibit disease? And if so, at what level and what service is in the best interest of this disease level? The next part of consistent messaging is making sure, and this seems simple to some, but this is the difference between a hygienist recommending or a doctor recommending periodontal therapy and or not. So even though all of us went to hygiene and dental school, there are still philosophies out there on how to probe that are not congruent. They're not equal. Some of us were taught that no matter what, you always keep the probe at the long axis of the tooth. You keep it parallel with the long axis of the tooth. And then some schools and colleges, and most recently, are showing that there needs to be a slight angle in the caul space, about a 10-degree angle into the caul space, so that we can get a true measurement of this bone right underneath that contact in the caul space. Otherwise, that bone loss can go undetected. So first of all, making sure that everybody is probing the same way and angling the probe into the caul space, walking the probe around all areas of the tooth, not just a 6-point insert and take it out. The patient can lose bone on the direct buccal and on the direct lingual line angles, as well as those direct surfaces. So we need to be walking the probe all the way around the tooth. So get out a probe and look at it. That's the next thing. So how are you, observe each other. How are you walking the probe around? And then pull the probe out and everybody gather around and let's calibrate. At what level, at what line do you call it, Mary, a 4? And Jamie, when do you call it a 4? Or when do you call it a 5? And so getting the angle down and making sure that everybody is angling and walking the probe along with calling out the numbers at what level on the line, making sure your probes are in good condition too. Probes wear out. We forget that, but probes do wear out, and making sure that the probe is, the numbers can be seen, or the lines can be seen, clearly, and that the end is not worn out is important. Also, doing the tissue response or sweep that I mentioned earlier is important, because that's the difference between active infection or not. And we all know that the whole epithelium wall is a part of the disease process. How many of us go in after we've just done a spot probe, or we've done a probe and we've only recorded the bleeding on probing, we get started and all of a sudden they start bleeding like crazy, and it's bleeding that we didn't get. It's because the backside of your instruments are now rubbing up against that epithelium wall. That's exactly what this doing this tissue sweep will recreate for you or will create for you. So you have, before you get started, a very true and clear idea of what their disease level is at. So continue to build value to the hygiene appointment is important. And our verbal skills and what we say are very important. So we've been primarily focusing on our verbal skills as it relates to the assessment of the patient. But now to continue to build value, let's talk about 4 key phrases that help us continue to build value for the dental hygiene appointment. And I notice here that one of my slides, the third point included in your visit is worded twice. That third one should say based on your findings. Based on your findings today. So that third bullet point there is based on your findings today. I apologize for that. But so as I mentioned earlier, using the verbal cue included in your visit today, that is an effective way to communicate that the doctor feels strongly about X, Y, and Z procedures that he or she is including complimentary into this visit, X, Y, Z. Patients feel like they're receiving extraordinary care without paying any additional fee for it. We discussed using it earlier when we were talking about the example of the periochart, including in your visit today as a periodontal screening. Another example is included in your visit today is a comprehensive head and neck exam. Or from the treatment side, you could say in the appointment, we simply say included in your preventative maintenance appointment today is a therapeutic air polishing, if you use air polishing. So using verbal skills like that for included in your visit really brings out the extraordinary care that you are providing versus doing it in silence. When preparing to present the treatment needs to the patient, it's really important and helpful to first highlight any of the positives that the patient is presenting with. So before you discuss the treatment needs, it should sound something like this. Mrs. Jones, the good news is the gum tissue around the crown that Dr. Smith placed last summer, it looks great. And I'm noticing that your plaque control is so much better. I am concerned about the filling on this back tooth. I am going to use my camera so you can see exactly what I see. Mrs. Jones, is this tooth sensitive yet? Leading in with a few positives helps reduce the common thought that the patients have, that every time I come in, they always find something wrong. After stating a few positive and switching your concerns to findings is an effective way of clearly communicating the facts, not just your opinion of what you see. Instead of saying, I see a cavity on this tooth, you could maybe say, your x-rays reveal that you have a cavity under that old silver filling. Or in another example, maybe instead of saying, I found several areas of bleeding, you can maybe say, you have moderate bleeding around your molar teeth today. So taking out anything that you found as a clinician, or I found as a clinician, will and putting that disease and putting the disease where it should be, is just on the patient, is going to help the patient own their own condition and disease. Get rid of the minimizing words like you have a little bleeding or I think you need, or instead of saying that, you could say, doctor and I are concerned about the amount of bleeding you're having today, or we're concerned about these numbers that have appeared to have gotten worse. How about you? And lastly, communicating urgency is something that we need to also bring up. Doctor and I are concerned about this. What about you? It is an important step in the communication process. Patients need to know the difference between something that's nice to do and for a procedure and what is a must-do procedure. If we're unclear or wishy-washy and we use minimizing words in our discussion of the treatment needs, it's unrealistic to expect that the patient is going to take action and move forward with the treatment recommendations. Our patients will never value the services that we recommend more than we do. So getting your strong why as to what you're recommending, getting rid of minimizing words, and shifting that the disease is their disease in your verbal skills is going to make the difference in how they hear the message. If you say, I found, they're going to maybe say, well, I didn't find it, you found it. So you keep it, I don't want it.